last day, so they're putting it on, put it on record to give other people the go. All right. Thanks, Neil. Again, my name's Ron. We're going to talk about your having your surgery today. It's very informal. Any questions as we're going along, just give me a holler. And if I don't know the answer, I'll try to get you the answer today. If you need to go to the restroom, just go through the door, make a left in the hall, make another left. The restrooms are right there. I put a bag there for you. That's got Hibiclens in it. It's a soap. We're going to talk about that for cleansing the skin and that before your surgery. I gave you also a handout. I'm going to be reading down through the handout, but highlighting on things, talking about things as we go along. I'll be talking about 3 different sections. I'll be talking about the day before your surgery, the prep day, and we'll be talking about the day of your surgery, and then basically the week after your surgery. We'll probably be done about 9:45, 9:30, anywhere from 9:30 to 10 o'clock. Depends if you have questions and stuff, how long it takes. Again, very informal. Just give me a holler. So we'll get started. So you can follow along on the handout there. This is the day before your surgery. If you're having your surgery on a Monday, this would be Sunday. You're only allowed clear liquids throughout the day, like broth, water, juice, apple, cranberry, white grape juice, Gatorade, Jello, coffee, tea. No dairy products though, nothing with milk. No milk in your coffee or tea. You may have like icicle pops, but nothing with the ice cream inside. You should also avoid carbonated beverages. That tends to produce more gas in your intestines. You don't want to be producing gas, so stay away from the carbonation. No alcohol, no solid foods. You also should be off your aspirin, any blood thinners for the week before. Have any pain or discomfort, you can take Tylenol extra strength or Tylenol, regular Tylenol. Also, you shouldn't be taking anything like vitamin E. Herbal supplements, anything you get like GNC or over the counter at the pharmacy, you should stay off that the week before. Some of that can have some blood thinning properties in it. It's not as well regulated, so rather you just stay away from it. I want you to continue taking your routine medications, heart medicines, lung, anything for your lung, for breathing, blood pressure medicine, anything like that, continue taking. Plus, you're going to take it the day of your surgery. I'm going to talk about that in a little bit, when you should take that also, what you should be taking. It's important to keep your fluids up that day. You want to drink at least 3 quarts of fluids throughout the day so you don't become dehydrated. Early signs of dehydration are chills. If you're feeling like a little achy, a little fluish, you should take on some more fluids. Because you are drinking fluids, you're not eating, your stomach may get upset. You can take anything over the counter like Tums, Rolaids, anything you normally would take for upset stomach. You may have a couple pretzels, or like a couple soda crackers, not a bag of pretzels, not a box of crackers, just a couple take the edge off if you're nauseous and you just can't get over it, just to get something in your stomach. This is the day you're going to be doing a bowel prep. The bowel prep is, you probably all have had colonoscopies, and it's basically the same thing as having the bowel prep for the colonoscopy, except we're not concerned about what fluids you're taking, what colors it is, because we don't care what, we're not looking for it, like reds or anything. You can drink whatever you want. So sometime before this, you want to go to the pharmacy and pick up a bottle of magnesium citrate, and you want to get Ducalax laxative tablets. Now you want to make sure you get laxative tablets. You may also get stool softeners, because you will be on stool softeners after the surgery, but you want to make sure you get the laxative tablets. At 12 noon, you're going to drink that full bottle of magnesium citrate. 30 minutes later, half hour later, you're going to take 4 of the Ducalax laxative tablets all together at one time. They are both laxatives. You're probably going to experience some abdominal cramping, some bloating until your bowels start moving. How long it takes? Usually within an hour or so, your bowels start moving. And if you've done this before, you know you're going to be in the bathroom, you're coming out, you think you're done, you're going to have to turn around and go right back in. So stick close to the bathroom, you're going to be in there most of the rest of the day.
That magnesium citrate, is that one size bottle?
Yeah. Yeah. You can, when you go to the pharmacy, you can ask them about it. It's for I'm not sure what the ounces are on it off the top of my head, but it's for the bowel prep.
I thought just they didn't want to, like if they had a,
yeah, you don't want to get a gallon of stuff. It's just like a 12-ounce bottle. All right. Yeah. So you're going to start. You're going to start out with diarrhea. When it comes towards the end, it's basically just to be colored water. Remember what you drink, what goes in comes out. So if you dry, say you drank some Hawaiian punch or something like that, and it's red, don't be alarmed if the water at the end is red. Yes.
The one paper that I took home said I could have ginger ale. Is that true?
Yeah. You can have ginger, but you're better off if you even let it go flat a little bit, because
Okay.
that's the carbonation again. The carbonation can cause you to get gas, and you don't want to get the gas production. You're going to end up passing colored water. You may see some blood. If you have internal or external hemorrhage because you're going so often, you may start having a little bleeding. When you wipe yourself, you may have a little blood in the tissue. We suggest you just, don't wipe yourself hard when you start out. Get like Charmin extra soft Charmin. You can use the Tux wipes, Preparation H wipes, Preparation H, anything to make yourself comfortable. So after midnight, there's no broth or jello. You may have up to 12 ounces of clear liquids up until 2 hours prior to your scheduled arrival at the hospital. Then after that, you should have nothing by mouth. You shouldn't be eating or drinking anything. There's no mints or candies after midnight. No tobacco products, smoking, chewing, vaping. No chewing. Chewing gum is permitted. You may chew gum. Now this 12 ounces up to 2 hours prior to your surgery. At one time they used to say it was always, don't eat anything or drink anything after midnight, or NPO after midnight. They've changed their thoughts on that. What they're recommending now, about 2 hours before you're going to leave the house to come to the hospital for the surgery, they're recommending you take about 12 ounces of like Gatorade or Powerade. It's got electrolytes in it, and they're finding that people have a better recovery after the surgery, anesthesia, and that when they have some electrolytes or some of that fluids on board. And that's the time you should take your routine medications, like anything for blood pressure or your heart or breathing like that. If there's any questions on your medications, call the hospital and ask to talk to the anesthesia department and ask them if you should be taking your medication that day of your surgery. But usually they want you to take your blood pressure medicine, like I said, anything for breathing, anything like that. So take that 12 ounces about 2 hours before you're going to leave the house. Now the next part down here, this is about starting 3 days before your surgery. They want you to use this HIPAA cleanse. That's the cleansing of the skin. There's two different sets of instructions. The hospital's going to give you an instruction. You might have got that already. And ours, follow the hospital instructions. They might not start 3 days before, but you want to be using it, taking a shower and using the soap. The next page, it tells you how to use it. About getting it wet, cleansing the skin. You should use it the night before, plus the morning of the surgery. Put clean linens on your bed. Use a clean towel. Use clean pajamas or t-shirts or whatever you're wearing that night. It really cuts down on the risk of skin infections after the surgery. Okay, so you should report to the hospital about 2 hours prior to your surgery. So if your surgery is, say, scheduled for 9 o'clock, be there about 7. If you're scheduled for 7:30, that's at LGH. That's the first time slot for surgery in the morning. Just get there about an hour and a half ahead of time. But any time after that 7:30 start time, get there 2 hours ahead of time. Any questions? All right, the next page here, it's got 3 columns. I'm going to go down the column on the left, center column, and then the column on the right. When you're going to the hospital, the only thing you need to bring with you is you bring your insurance information, your insurance cards, and some type of identification like a driver's license. You don't need credit cards, no cash, no jewelry. Leave all that stuff at home. You may bring your cell phone. You can use your cell phone while you're in the hospital. But like I said, only insurance information and a driver's license. So soon after you arrive there, someone's going to talk to you about your current living arrangements. And this is if you want a visiting nurse to come in the home for a couple days after your surgery. And that's your decision. They'll talk to you as you're coming in, and they'll talk to you the next day on discharge also. If you want one, they'll make the arrangements for a visiting nurse to stop by. Most people don't if they have somebody, a spouse or somebody at the house, but that's your decision. You want to wear comfortable, loose-fitting clothing. sweatpants, lounge pants, shorts, t-shirts, things like that. You don't want belts, you don't want anything restricting it, and that's what you're going to be living in the next week or so. Just loose-fitting, comfortable clothing. So you may not eat or drink anything before your surgery, except that 2 hours prior to leaving the house. You should have that 12 ounces of like Gatorade. Soon after you arrive, also the anesthesiologist, the nurse anesthetist, is going to be talking to you about any prior surgeries, any problem with anesthesia, any allergies or anything. They're going to start an IV. They're going to give you a medication, and you will calm down. You'll be relaxed. All the anxiety will be gone. You may not remember much after that, but you will be awake. But you may remember everything. Some people, it gives a little amnesia. They may not remember anything, but you'll follow instructions and do whatever they tell you to do. The nurse is going to shave your belly, and then they're going to talk to you about using, this is called a Boldine, or what they say is a blow bottle, but it's not really a blow bottle. It's for taking deep breaths in. What you want to do is put it on here. Take a real deep breath in. There's a disc on this particular one. See how far you can raise the disc up. Some of them have like 4 rows with colored balls in. See how many colored balls you can get up in the tubing. You want to do this. Take a deep breath in 10 times in a row, slowly. Take a deep breath in. After the surgery, do a little coughing. Split your belly with your arm, or put a pillow there. Do a little coughing. Get anything up that's in your lungs. Anything. Your risk for pneumonia bumps up a little bit because having surgery in the hospital. This is to help prevent pneumonia. So you want to do this about every hour when you're in the hospital. When you wake up, or when you get up to your room, this will be sitting at your bedside table, sitting there, pick it up. Do 10 deep breaths in a row. Again, not real fast. Don't get lightheaded, dizzy. Do a little coughing, and do it about every hour. You're going to take it home with you, and that first 24, 48 hours, it's important you use it every so often. After that, it's not as important because you're going to be up moving around, you're getting back to your normal life. But those first 2-3 days, it's important to use this. Again, it helps prevent pneumonia. Okay, so now the family, they're going to take you down to the operating room after you're all prepped. Family's going to follow you down to the surgical waiting area where they're going to wait for the surgery if they want to be there to wait for you to come out of surgery. We'll receive updates during the procedure, and when the surgery's done, the doctor's going to come out and talk to anybody, family members in the waiting room. I'll talk a little bit about the surgery. If this is the operating room, this is, say, with the operating table, they're going to bring you in on the room on the stretcher, have you move off the stretcher onto the table. Once you're on the table, you're going to have, there's going to be an anesthesiologist, the doctor of anesthesia. They're going to be there, but they won't be there during the whole procedure. They're usually working between 2 or 3 rooms right side by side. They're rotating through. There will be a nurse anesthetist there at all times administering anesthesia and monitoring your vital signs. You'll have a nurse on the left side of you. You will have a nurse on the right side of you. Plus there's a nurse that floats through the room. Then your surgeon, they will be sitting off to the corner in a booth working the robot. So the first thing, once they get you on the table, they're going to put you to sleep. They're going to give you some medication. You'll go to sleep, so you won't have any pain. You won't know anything after that. Then your doctor's going to come over. Now, you don't have a formal incision. You're not having a big incision, but they do have to poke some holes in to be able to get the arms of the robot in to do the surgery. So when they come over, they have it's almost like a spike. It's a little bigger than what my pen is, and it has a plastic sleeve over it. What they do is they put the first hole they're going to poke in just either above your belly button or just below your belly button. He's going to poke that in, take out the inner spike, and it leaves the plastic sleeve, so you've got a whole opening there. And you're going to go on either side. You're going to poke 2 more holes. Just go about a little bit further. You're going to poke 2 more holes. And someplace along the line, they're going to poke another one. Usually it's a little lower in the pelvic area, so it gives better access for the instruments for him to do the surgery. Then they take their robot, and it's shaped like a letter N. They roll that over top of you. They're going to take the first one where they poke the first hole. That's where they put the camera in for the robot. They put the camera down through that hole to be able to visualize to do the surgery. Then the other ones, they put the instruments on the end of the arms of the robot. Nothing's larger than the size of a dime. You got little scissors, you got little forceps, little suture holders, different things like that to do the surgery with. So you go insert them down. Once he has them in place, he's going to take your legs and put your legs up in stirrups, just like you're going to have a baby. And that's what that's about. Well, then after he has your legs in stirrups, if this is your legs and this is the head end of the table, he's going to tilt the table down a little bit so your head is lower than what your legs are. And this is what part of the bowel prep is about. The bowel prep, it cleanses out the bowels, get all the material out of there, but it empties it out so when he tilts you down, it's empty and your intestines and your internal organs shift up towards your chest cavity, so it really opens up the pelvic cavity that they can move the instruments around and do the surgery. Once he has you in that position, he's going to go over and sit down at that booth. He's going to hook up the robot to himself. He puts them on his fingers, so he moves his fingers. He's working the arms of the robot. Plus, he's in his stocking feet. He has foot pedals, so he's working foot pedals. Plus, he's working the fingers, and he's sitting there looking in a viewfinder. When he's looking in the viewfinder, it's basically as if he's sitting right inside. When he moves the camera, it's like he's moving his head and his eyes. It's all basically microscopic surgery. He's sitting right there. So he starts on one side where they check the lymph nodes. If they look at the nerve of the penis, they feel the nerve of the penis is compromised, they will take the nerve of the penis. But part of this is to try to leave the nerve of the penis. So they're going to try to leave it if it doesn't look compromised. Starts on one side of the prostate. See the bladder side, he cuts away, resects the prostate away. Very little blood loss because he's right there, right on top of it. When he gets any bleeding, he usually can touch it with a little electric cautery and burns the ends of the blood vessels shut. Once he has that cut loose, goes to the other side, cuts that loose. Once the prostate is loose, cut away, takes the plastic drawstring bag, puts down the tube, picks up the prostate, puts it in the bag, ties it up, and pulls it out through the tube. Goes back in, takes the bladder, the urethra, pulls them together, sews that around. Then he takes the catheter, puts down through the piece in the bladder, and that catheter is going to be in there for the week after your surgery. So that when the urine comes down, it just drains out and goes into the bag to let that heal together where he pulls the urethra and the bladder together. The surgery, it is microscopic surgery, it is time consuming. The surgery, if your schedule say 9 o'clock in the morning, and this is for family members, you're sitting and waiting in the waiting room. The doctor, you may not see the doctor till after lunch, afternoon, until maybe 1 o'clock. If you start at 9 o'clock, this surgery is anywhere 3.5, 4.5 hours, maybe a little bit longer. It's about 30 minutes to they're in position and ready to do the surgery, to start the surgery. Then it's 3.5, maybe 4 hours to do the surgery. Then it's another 30 minutes to get everything out and into the recovery room. And when they're in the recovery room, that's when your doctor's going to come out and talk to family members. So don't be alarmed. You're sitting out there and say, "What's taking so long? Something must be wrong." It's a 4.5 hour procedure basically. So it's going to be it's a long wait when you're waiting out there. All right. So your surgery's done. You may remember the recovery room. Most people don't. The next thing you'll know, you'll wake up. You'll be coming to in the room upstairs. So soon after you're awake, they're going to have you up. They're going to have you out of bed. They're going to have you walking. All right. That same day you had your surgery. When you're in bed, you're going to have these stockings on from your knees down to your ankles. They wrap around, and it's just like a big blood pressure cuff. And you'll hear a pump kick on, and you'll feel pressure just like a blood pressure cuff on your lower calves when you're in bed. When they get you out of bed, they'll take these off, but when you get back in bed, they're going to put these back on. And that's what they are. They're like a big blood pressure cuff, and what they're doing is to help prevent DVTs, or deep vein thrombosis. Your risk for a deep vein thrombosis bumps up a little bit more after surgery because of the surgery, length of the surgery. Your legs are up in stirrups, you're tilted back. So they put these on to help prevent DVTs. You're not going to have these when you go home, but if you want to, you can get some compression stockings or stockings that are a little tighter. You can wear them. Sometimes they put you on a little bit of a blood thinning drug to help prevent it. But if you're at home and you start getting a Charlie horse in your calf or in your leg, or swelling up, you can't walk right, you're having pain, why don't you call the office here? We're going to bring you in here, send you downstairs, the X-ray department's right underneath us here, and have them do a Doppler ultrasound. It's just a probe with a little gel on it. What they're looking for is a blood clot. They don't find one. You go home. You're still having discomfort the next day. You're having pain. Give us a call. We're going to bring you in. We're going to do another Doppler ultrasound on you. We'd rather bring you in that we can do half a dozen ultrasounds on you than miss a blood clot. If you can't breathe, you're having chest pain, shortness of breath, call 911. Get to the emergency room. You can have a pulmonary embolism, a PE. Anytime you have surgery or anything, all that bumps up a little bit. So don't sit at home thinking, well, this is go away. Call the hospital, get 911, get an ambulance, get to the emergency room. They'll let us know you're there. A couple years ago, I talked to a spouse. It was a couple months after I had a class, and talking to her and said, how he did. She said, he sat at home for 3 days with a swollen leg, couldn't walk, he having pain. Then he couldn't breathe, he had chest pain. So he had a DVT, and it broke clot off, and he had a pulmonary embolism. Everything turned out all right. He recovered, but she said to me, I talk about it in class, which I do, but you're taking a lot of information here. But if you take anything out of this, remember that. Don't fool around with that. Get to the hospital. It's rare, but it does happen. All right, so these pump stockings are going to be off your legs out of bed. They'll put these back on when you get in bed. You're probably not going to really feel like eating or drinking anything. Your mouth's going to be dry and that. Do whatever you can to get your mouth back, that bad taste out of your mouth. Brush your teeth, mouthwash, push some fluids. My suggestion is ask for a cup of ice chips. Start chewing on some ice chips, sucking on the ice chips. That helps get some fluid in your mouth, gets that taste and gets that dryness out of your mouth. You're going to have an IV. There's going to be pain medication available, but you need to ask. Let them know you're having pain. They'll ask you to rate your pain from 1 to 10. And there's orders there, and they'll give you what they feel that will take care of your pain and make you comfortable. And take the pain medication. You do better when you're more pain-free when you're relaxed. So, don't sit there and think, well, I can tough it out. Take the pain medication. You want to be comfortable. You want to be relaxed. You're going to have nasal cannula in or a face mask on. You're going to have oxygen from when you first come out. They're going to be monitoring your heart. They're going to have a heart monitor on you. You're going to have a catheter in place. That tube's going to be there, and that's going to be there for the next week. So you want to pick up the Voldyne, the blow bottle, start using that, taking the deep breaths, 10 deep breaths in a row, do a little coughing, splitting your belly with your pillow or with your arm. You're going to probably have a drain in. One of the other things, also when you come out of surgery, you may be a little puffy, you may be a little swollen around your face. That's not only like around your eyes, maybe around your jawline and stuff. It takes a day or so for that to go away. It's because you're tilted down, they're pushing IVs and stuff. So it might be that nobody was slapping you around when you were asleep or anything. It's just from the fluids being pushed and being laid that way. And about a day or so that should be gone if you have it. This is the drain. It's called a Jackson-Pratt drain. It's got a bulb here, silicone tube. From here on the tube down, you can't see, but it's filled with a bunch of tiny little holes. So they did the surgery, and after the surgery, everything's closed up, everything's sealed up. But in there, where they took the prostate out, you're going to have a little oozing. You may have a little blood. You may have a little what we call serous fluid, cell fluid. And normally, when that's oozing, when it comes out, that your body reabsorbs that. But if you get more than what the body can reabsorb at one time, you start getting a collection, and then you can get an abscess in your pelvic area where you had the surgery, which they don't want you to have the abscess. So after the surgery, what they do is take this.
He's a passer-outer.
Okay. If you want to get down on the floor, you can lay down on the floor if you want to.
I just need to bend over, I think.
Yeah.
Catch my breath.
Or I yell at him, not usually.
No, he's not the first one. About every third class, I have somebody that, it's just the anxiety.
Mm.
They say if you want to lay down on the floor, get your feet up a little bit, you can do that.
Sit
No,
down, please.
I'm good.
You're good?
Yeah. The worst part, I think, past the little
Yeah.
dizziness.
You
I'm
okay?
good. I'm okay. I'm all
Right.
right. I won't fall off the chair.
All right.
Not usually.
It's when you get the anxiety, then it gets worse.
Yeah.
You know, you think about. So, well, I'll talk. Just give me
I'll
on.
watch you.
So this has all these little holes. So after the surgery, what they do when they're taking the instruments before they close the hole up, one of them they slip this down through, and this lays in down around where the surgery was. This comes to the outside. This bulb is collapsed down. And what it does is puts a low-grade suction in that area. There's a little tab here on your gown. This is a safety pin. They have it pinned to your gown. If you have, most people are going to have this in. 90% of the time they put this in right after the surgery, but they take it out the next day when you're being discharged, when you're going to be out to go home. If they feel there's more fluid in there than what there should be, you may go home with it. If you do go home with it, you're going to call the office, somebody from your family, or you're going to call the office the next day. On this bulb, there's lines, and it's marked 100, 75, 50, 25. It's milliliters. And what you do is when you call the next day, just tell how much came out in the bulb. And if that's usually, if you do go home with it, we're going to have you come in the office the next day and we take it out. It's held in place. There's just one little stitch on the skin they tie around the tube. You nip that stitch, take it off, and this slides right out, and you really don't feel anything. You might feel a little drawing sensation, but it's not painful. You shouldn't feel much anything. Yes.
We don't pump that thing on, do we?
You don't pump
They
the
do it
thing.
from the
It's going to
hospital.
be collapsed
Okay.
like this. If it would get full, they would show you how to empty it.
Okay.
You know, if you're getting a lot more fluid out, but usually you don't have that much come out. There's just going to be, they don't want a large collection in there, and that's usually within the first 24 hours or so.
Okay.
You want your body to reabsorb any fluid that's coming out, any cell fluid. You want a drink?
I got
Oh,
it.
you got a drink there. Yeah.
I'm
Okay.
good.
But light.
The worst part's over now.
Yeah,
I'm good.
okay, all right. All right. So third column here, if you meet the discharge criteria, that next day, you're going to go home from the hospital. They have, if you want visiting nurses and that, this is when they'll arrange it for you a visiting nurse to come in daily for a couple of days to check you. Your appointment will be made, you probably have it already for your follow-up appointment the week after your surgery. That's probably been made already. So you're going to be sitting up in a chair. You're going to be out of bed walking on your own as you progress. You may get dizzy, so when you're on your own there before you're discharged, get out of bed or sit there on the edge of the bed, make sure you're not dizzy. Then you stand up, make sure you're not dizzy, hold on to the side of the bed. If you're okay, get out. We want you walking around. Two things that week after surgery is walking, getting up, exercising, you're walking, moving around, and fluids. We want you drinking water, lots of fluids. So you're going to have full liquids for breakfast. If that's tolerated, okay, they're going to increase your diet to high fiber at lunchtime. Nurse probably going to be coming in once in a while listening to your belly with a stethoscope, and what they're listening for is bowel sounds, gas moving, that your intestines and your bowels are starting to work again. And you probably, when they start, you're going to probably get some gas pains. Best thing to do for that, to get the gas moving, is walking. So we want everybody out in the halls walking, passing gas. Don't be embarrassed. That's what everybody's out there trying to do, get comfortable passing gas. But that's a good thing. That's your intestines are working and things are moving. Yes.
When we go home, do you want, when you say walking, are you talking just walking around the house a little bit or going outside?
You'll be outside. You do whatever you want. I'm going to talk a little bit about that in just a minute here, about that, getting out and moving around. So, so don't expect your appetite to get back to normal, but you need to drink. We want you drinking fluids. There's going to be medication available for bladder spasms, pain medicines. I'm going to talk about the medicines now, what you're going to be on. Okay, when you're discharged, they're going to give you a prescription for a narcotic, okay, for the bigger drugs for pain, a narcotic to pick up on the way home. When you get that, you don't have to get a full prescription if you just want to get a half prescription. Everybody knows by this age now what your pain thresholds are. You know if you're going to have a lot of pain, you're going to need heavier medication, or you don't need as much medication. Everybody kind of knows where they stand. That first day at home, you might want to use a narcotic, but if it's not, you don't need as much for pain control, but you need something, extra strength Tylenol is good. If the extra strength Tylenol takes care of your discomfort and makes you comfortable, so be it. You don't need to take the narcotic. Side effect of narcotic a lot of times is constipation and things like that. Sometimes that can be worse than what the pain was before. You get constipated, then you don't know what your pain's coming from, the constipation or from the surgery. So if you don't need to take the narcotic, and if Tylenol extra strength does it for you, that's great, so be it. So you're going to have the pain medication. You could be taking Tylenol extra strength. You're going to be on a stool softener. You will not be on an antibiotic, but they'll have you on a bladder antispasmodic. The name of that is either Ditropan, the generic name is oxybutynin. After your surgery, your bladder's not going to be happy. Your bladder's it's going to be empty. It's sitting there with a tube in it with a ball on the end rubbing against it. It just had the surgery on the outside. Your bladder's going to be all red and irritated. And you get these bladder spasms where the bladder contracts down. It's like a real urge to urinate, and they can be really uncomfortable. They can be painful. In fact, it cramps down enough. It's like a bowel cramp, but it's in your bladder. You can spurt a little urine, a little bloody discharge out around the catheter. They don't want you having them because it doesn't help with the healing process. Plus, you're uncomfortable. They hurt. So they give you this drug called Ditropan or oxybutynin. It's a bladder antispasmodic. It's a smooth muscle relaxant. It basically paralyzes the smooth muscle in the bladder so it can't contract like that. You may still occasionally get one breakthrough during the day. That's normal. If you're getting more than 1 or 2, 3 a day, you're uncomfortable, give us a call. They can switch you to another medicine. The Ditropan might not be working the best for you. They give the Ditropan. So that was probably the first one out there on the market. There's probably 10 other ones now, but the Ditropan works well and it's cheap. It's pennies. It's very inexpensive. Some of the newer stuff they charge you a lot more, which doesn't matter when you're uncomfortable. You pay for it, but the Ditropan usually works. Side effect from the Ditropan is a dry mouth. If you get a dry, cottony mouth, it's from the Ditropan, which in one respect it makes you want to drink more water. So that's good for that. You get some more fluids on, but that's the side effect of the Ditropan. The Ditropan you're going to take that whole week, but we want you to stop it the day you're coming in to see the doctor. You're done, because we want the bladder to resume its normal function, because we want to get the catheter out. So you're going to stop your Ditropan, or the oxybutynin, the generic name of it, but you're going to start an antibiotic. They're going to give you a prescription for an antibiotic pill. So you're going to start that when you stop the oxybutynin. So you're going to be on the antibiotic. It'll be 5 to 7 days after the catheter's out. You're going to be on the antibiotic after the surgery. So don't be surprised when you're going home. You're not going to be on the antibiotic, but you will be on one when you're coming back in to see the doctor to get the catheter out. And those instructions will be all on there too, plus it's in here. Any questions on the meds? Alright, so the oxygen and the heart monitor is going to be removed that morning. You want to continue using the blow bottle, the Bulldyne, split your belly with a pillow. Abdominal drain is going to be pulled out, should be taken out if you have one. Most likely you will, but they'll take that out. The catheter is going to be left in there. That's going to be in there for the next week or so. So they're going to show you how to do your incision care, take care of your incisions. They're going to show you about your catheter, your bags and everything. I'm going to talk about all that here. They're going to encourage you to do your Kegel or pelvic floor exercises. That's to help to keep you get dried up, get your continence back after the surgery. And I'm going to be talking about that in a little bit. Any questions there so far? All right. Now, when you get home, hopefully you're gonna a couple of days you're gonna feel pretty good. You don't have a big incision. You're just gonna have a couple of these little slits. The slits, there's no stitches or anything. They're glued shut. hopefully you're going to feel pretty good. But it takes 6-8 weeks to heal. You did have major surgery, so you want to get adequate rest, nutrition. The body needs to heal, so I want you to follow these instructions here. You want to eat and drink what you like, but you want to include foods high in fiber. You want to drink at least 2 to 3 quarts of fluids every day to keep the urine flowing to help prevent constipation. Straining for a bowel movement can cause blood in the urine. Here, bold letter says, do not strain. And, you're going to have some straining when you have a bowel movement. That's normal. You have a little bit of straining every time you go. But we don't want you to get constipated. So, keeping the fluids up keeps the urine flowing, keeps that clear, but also, the bowels, the stool takes a lot of fluids. So the more you drink, you get fluids into the intestines, and that helps you from getting constipated also. The straining, you are going to bear down a little bit. You may see a little blood in the catheter or when you go around the tube after a bowel movement. When the stool passes, that's going right over where your prostate was. So that's pressing against it as you have a bowel movement. So you may see have some blood, a little discharge out around the catheter, a little discharge here. The urine may get a little bloody right afterwards. Just relax, push some fluids, it should start clearing right up. And you can shower daily or more than daily, but no tub baths. Don't want you sitting in a tub of water that week when the catheter is in there. After the catheter is out, then you can get back in a tub bath if you want to. But before that, when the catheter is in, stay out of sitting in water. Showering is fine. You want to keep your incision clean. You want to keep it dry. Wash your incision with soap and water only. Look at your incision daily for any signs of infection. That's redness, heat, swelling, drainage. Continue to support your incision with your hand or pillow with any exertion like coughing or sneezing. Continue to use the blow bottle periodically at home. So the incisions, like I said, they're going to be little slits, no stitches. They're glued shut. When you're in the shower, just let the water run over it, wash it off with soap and water, dry it off. No dressings, no ointments or creams on them. You may put a little dressing over top if they're tender, to a shirt rubbing against it, something like that. But if you can, you're better off leave them open to the air. They heal better. They may be a little red and a little puffy when you go home, but they should get better. You shouldn't get more swollen. You shouldn't be getting fluid leaking out or serous fluid with bloody discharge from them or a little pus or anything come out. Then they're getting infected. There's that, and that's what that HIPAA cleanse is to help prevent that you're prepping with soap before. But they should improve. If they're not getting better, they're getting worse, give us a call. So the following are the limitations. There's no heavy lifting, no pushing, straining, pulling, no sporting activity. They will talk to you that week when you come back about resuming any activities like sporting activities or exercise activities. Bicycles are a no-no. Don't want you sitting on a bicycle. Sitting on a bicycle seat, try even up to 6 months. So that's right where you had your surgery. When you're pedaling in that seat, that's pounding that area. So we don't want anything like that. No lawn work, no snow removal for that week. No driving of a car. No riding in a car longer than 40 minutes. Like if you're going someplace, I realize we're in here around the holidays and stuff, people are traveling, but if you're driving someplace and you're sitting in a car, you should 40 minutes or so, pull over, get out, move around, get a little exercise, get moving around. Everybody cheats. I said about driving a car, and the different doctors have different feelings here. But if you get halfway through the week and you're feeling pretty good, and you just got to go like a mile to the Turkey Hill to get a gallon of milk or something, they don't have a problem with that. If you're okay, if you're feeling okay, nothing. Just short distance, you could do something like that. Don't want you driving around all over the place, but something like that. Like I said, I know I did when I had surgery and stuff. You have a tendency to cheat. My wife would holler at me after she found out, but you have a tendency to cheat. So just make sure you're all right. The following activities are walking and going stairs. Be sure to start out slow with any walking on the stairs. Protect yourself from injury or overexhaustion. So when you get home, especially that first day, you can get out. But don't go real far. Get out. You can go outside, work short distances. A block or two. Come back and forth. Stay closer to home. You don't realize what it takes out of you. You'll be doing it if you're out there, say a half hour, and all of a sudden you hit a wall. You don't want to be a half mile away from the house and you hit that wall. You think, holy cow, I don't know if I can make it back to the house. Because it does. Make sure you have your stamina back. Make sure that you're back to normal. And that usually takes a day or so. But once you know you have it, you can walk as much as you want. Go the stairs, that's okay. Don't want you to run up and down stairs all day, but you may go stairs and stuff. But we don't want you doing other things. Don't want to do a heavy lifting or pushing or pulling things and stuff. And that's a good thing. And that's what I say about fluids. I'm going to talk more about that here, but the fluids, you want to keep your fluids up. Think about it all day long, drinking fluids. You may not be eating as much as you were. It takes a couple days to get your appetite back, but the fluids you want to drink. If you're getting fluids enough in, you get up in the morning after night and you look in your bag, the urine looks like this, or maybe not quite this clear, but your urine's going to be pretty clear. That's good. But as you get active during the day, you take your shower, you're going for breakfast, and you may look at the bag, maybe pink, maybe a little red. That's normal because of the activity. You're going to be red, and you're going to be clear that whole week off and on. When you go out for your walk, you'll be clear when you go. When you come back in, you look at it, it's red. Push fluids, sit down, rest 10-15 minutes, look, you should see it clearing up. You're okay. A little blood goes a long way in the urine. It's going to take you a day or so to get yourself acclimated, that you look at that and you say that you're not bleeding to death. You know, you're going to look like, it's going to look like blood, and you think, oh, geez, I'm bleeding to death or something wrong here. If you push fluids, relax, watch it for 10-15 minutes, you should be clearing up. So once you do your Kegel exercises or pelvic floor exercises, remember they help with control when the catheter comes out. I'm going to talk about that more in just a little bit here. You may experience some swelling in your lower belly, your scrotum, penis, feet, or ankles. This is lymph swelling because of the surgery. If this occurs, elevate the affected area. The doctor wants the body to assume the job of taking the fluid away on its own. However, if it gets extremely uncomfortable, if it's swollen and it's not going down, give us a call. They can put you on medication, a water pill, or a diuretic to help you get the fluids out. So you may have some swelling in your ankles and your legs. Just sit in a chair, get them elevated up, see if you get that back, get it out into your circulatory, get it out so it gets out to your kidneys and pumps it out. An area you may have some swelling that you never had before is in the scrotum or in the penis area. And that happens. Get in again in the recliner, get tilt back. Take a hand towel, roll the hand towel up, tuck underneath, lift up the scrotum and the penis, get that a little higher than what your body is. That helps get the fluid out, gets back into your bloodstream. Try that first. You feeling okay?
Yeah, I'm not.
Still white?
Swelling.
What do you do?
Yeah, you will be for a while.
You sit and lift it up and put it
All right, you're probably going to experience some leaking around the catheter. This is normal from bladder spasms. Keep yourself clean around the catheter, scrotum, penis, inner thighs. Help prevent skin breakdown. The drainage can contain some blood and urine. So you're going to have a discharge out of the urethra around the catheter. It comes out from the penis. That's normal. As we're sitting here, the urethra, the tube from the bladder out through the penis, it's a mucous membrane, and it's secreting right now. It's secreting a little bit to help keep things lubricated, to keep things comfortable. You don't know that when you go to the restroom today, you're passing your water, anything that's in there, it just washes out. But when you have the catheter in, you're not urinating on your own, so it's not washing out, and you're producing more of it because the urethra is irritated from the catheter. So it's going to work its way out towards the tip of the penis. It'll be clear. It may be a little blood tinged. That's normal. Just keep it cleaned off with soap and water. When you get up in the morning, it might be a little crusty. When you're laying there, just keep it cleansed off with soap and water. That's normal. You're going to have that. Another thing I suggest, take a little Vaseline. Put a little dab of Vaseline at the tip of the penis. That helps to keep it lubricated, keeps it comfortable with the catheter in place. Don't expect your bowels to return to normal. It may say take some time, so you need to take the stool softener ordered by the doctor. You may use a little Milk-O-Mag or the Ducalax tablets, but no suppositories, no enemas. You don't want to put anything into the rectal area that first 6 weeks or so after the surgery. Some people, when they have get constipated and things like that, they use Fleet's enemas and stuff like that, but you don't want to do that because it's all inflamed in there. It's not as sensitive. You could poke the suppository in there, the enema tube, and actually poke through the bowel line and not know you did it until you start having problems. So you don't want to put anything into the rectal area. All right, so that week just flew by. You're ready to get in here and get the catheter out. So you're scheduled for what's called a VCUG, or it's avoiding cystourethrogram. That's done. That's done in the X-ray department. That's either you can have it done downstairs here. You could have it be set up. It could be scheduled at the hospital. And what they do when you get into the X-ray department, they get you up on the table. They disconnect the catheter from the bag. They put a syringe on the end, and they just take it. It looks like water, but they pour it. It's got some contrast material in it. They pour it in and fill your bladder up till you have a little bit of an urge to urinate, where you feel a little full. They clamp it off. They take a picture. When they take the picture, they drain it out, hook you up in the bag. Then usually you have an appointment right after that to come into our office here to see your surgeon, to see your doctor. So you get here after the VCUG, take you in the room. The doctor's going to look at that in our computer system. They'll have it send it over to our computers here. We'll take a look at that. And what they're looking for is to make sure it's healed up, make sure there's no leakage there where the surgery was. If there is a little leakage, you can see where that dye, you can see a little wisp of dye in there. Most times you're healed up, we can get the catheter out. Sometimes they have to leave the catheter in a couple more days to let it heal, a couple more days longer. People like that happens to is usually they're like diabetics. They heal a little slower, things like that. But sometimes it might just have to leave the catheter in an extra day or two. It's not that often, but it does happen. So after the doctor looks at it, he feels that it's healed, it looks good, we're going to take the catheter out. So the nurse is going to come in the room, they're going to get you up on the table, they're going to put some water in your bladder, just stir water, fill you up, take some stir water, take the catheter out. And we like to see you have you pass your water, see if you can stop it, see how good you have with control. You're probably going to have some leakage. Most times after the surgery, it takes a little while to get your urine control back, to get back to normal. Especially if you had a little bit of control problems before the surgery. But if you didn't, it takes a little time to get back to normal. That you're not having any leakage. So we recommend that once you bring underwear, but once you bring the jockey shorts, the tighty whities, like 2 pair of them. Okay, not boxers, the tighty whities. I want you to pick up some kind of incontinence pad. And they've been in the past, they've recommended Poise or 10 pads. I want a pad that fits in the front. Okay, we don't want you to get like diapers or Depends, anything you pull up. We don't want you to depend on Depends. We want you to get a pad in the front that you're going to, just to keep you from getting wet, to keep you from getting dry. So we're going to have you put the pad in the front of the underwear. We're going to have the catheter out. We're going to have you pull up the jockey shorts with the pad in the front of the underwear. They recommend that you take your penis, instead of just letting it lay down, see if you can pull it upwards, up towards your belly button, pull it up tight that way. They feel it helps you with a little bit of control. And most times you say, when you start walking, it just falls down and falls to where it normally lays. But they say, well, stop that, you can just get a roll of duct tape and duct tape around there and that'll keep it up. But I don't recommend that. So just do the best you can, put it up, pull it up tight. So you want to bring extra underwear in case you do get wet, and pads, and maybe even an extra pair of pants along. All right, so at home that week before, be sure to take the medications that prescribed. You want to keep all your appointments. Write down any questions you may have during that week. When you're at home, you'll think of things you want to ask, talk to. Basically, you get in the doctors, they've done enough of it, they know what you're going to ask, what you want to do, or what they know. Most times they answer your questions before you ask them. But write things down, because like anything else, there's a lot going on, there's a lot of things going through your head as we're doing this. And you're halfway home, you think, oh, I forgot to ask about this or forgot about that. So write it down. Ask them before you get out of the office here if there's any questions. So that week you're at home, what to call us about, what to make contact here with. If you have a fever 101.5 or more, if you have decreased or no urine output, if you empty your bag out and you're getting uncomfortable, you're getting discomfort, you feel like you have to urinate, you're getting some pain, you look in your bag and it's been 3 hours since you emptied it and there's nothing in the bag, there's something wrong, it's blocked someplace, so give us a call. And that doesn't really happen often, but it can happen. Pain unrelieved by the pain medication. Any pain or swelling in your leg, if you're getting swelling pain, well, you're going to call us, we're going to bring you in, we're going to do that Doppler ultrasound here, checking for a DVT, a deep vein thrombosis. Signs of infection at the incision, redness, swelling, drainage or heat. Foul smelling urine, heavy bleeding in the urine, some bleeding is expected. Chest pain, shortness of breath, call 911, get to the emergency room. The last one here says foul smelling JP drainage, but the JP tube should be out before you go home. The heavy bleeding in the urine, like I said, you're going to have bleeding in the urine all week long, and you'll get more accustomed to it after a day or so. You'll know what's going on when you see it red. But if you sit and push fluids and 15-20 minutes later it should clearing up, you're okay. Where your concern is if it would be a real bright red it's not clearing up, or if a dark red, really thick, even with clots in, it gets like ketchup consistency, that's more bleeding than what you should have. You should give us a call. We're going to get you in here and take a look and see what's going on. You all right? You
Yeah.
doing okay? All right, the next session here is about bladder control exercises. We're going to talk about doing exercises and what to expect. So bladder control after prostate surgery takes time to return. There are many factors that play a role in gaining control. The key factor in bladder control exercises, also known as pelvic muscle exercises, pelvic muscle tucks or Kegel exercises. These exercises can be started today. You need to be able to understand how to do the exercises and feel confident before your surgery. It's important to locate and identify the correct muscle to exercise. The muscle you want to exercise surrounds the urethra, that's the tube where the urine leaves the body, and the anus where the stool leaves the body. There are a few examples that can help you identify the correct muscle. When you go to the bathroom today, pass your urine, start and then stop your stream, and concentrate on the muscle used to stop your stream. That's the muscle you want to use for the exercise. Do this only as a way to localize the correct muscle. Don't do it as a way to exercise. So when you go to the bathroom today, when you're going in there, you're urinating. As you're urinating, stop it. Stop the flow. And in your head, think there where that's at in the pelvic area, down in the perineal area. Don't try to do the exercise first thing in the morning or when your bladder's full in the middle of the night and you're tired, or if you would have a bladder infection. There's different other ways here to figure out where you're going to be exercising that muscle. So pretend you're in a crowd of people and you have to pass gas, but you don't want to do so. You squeeze yourself tight to prevent that from happening. That muscle you're squeezing is the muscle you want to use for the exercising. Or pretend you have to pass your urine so bad that when you get to the bathroom it's locked, there's not another bathroom available close by. The muscle you're using to keep yourself from leaking, that's the muscle you want to use to exercise. Okay, there's many different variations in doing the exercises, but the key is to do them. One here is to squeeze and hold your pelvic muscle tight for the count of 10 and then release. You may need to work up to how long you can hold the muscle tight to prevent any discomfort. Do 10 repetitions 4 times throughout the day. These can be done in the lying, sitting, or the standing position. You squeeze and hold your pelvic muscle tight for the count of 10 and do 30 repetitions lying, sitting, and standing. Do this variation 3 times a day. You want to start them now and restart them after your surgery while still in the hospital. Remember, can cause a splatter spasm to occur or be uncomfortable, so you stop and you restart them later. If you don't start them now, then when the catheter comes out, it's imperative you start the exercises if you want to gain control. This exercise is important to help you regain control of the urine flow sooner and to help you keep control. So the ones the doctors here recommend is that first one right here, where you squeeze and you hold your pelvic muscle tight for the count of 10, and then you release. And you do the 10 repetitions in a row, and you want to do it 4 times throughout the day. Again, you can do it done in a lying, sitting, or standing position. So they're hard. They're a hard thing to do, but it's like anything else. It's like weightlifting. When you start doing, you're doing the repetitions. As you do them, and you goes further into doing them, they get better. They get easier to do. And you don't even think about them as you're doing them. But what you want to do is you tighten that up, like I'm sitting here. I tighten that up. When you tighten up, you can feel your penis pull back a little bit, maybe your scrotum move a little bit, but you tighten up and you keep that held, holding that, you count to 10, and then you relax it. And I'm tightening it up now again, count to 10, relax. You do that 10 times in a row, and you do that 4 times throughout the day. You might be doing them already. Somebody might talk to you about it already. You can, if they are, fine. But you should start doing that now. Start exercising, start doing those tighten up that perineal area. You want to continue doing them. You want to do them even in the hospital or right that week when you have your surgery, when the catheter is in, if you can. If it's too uncomfortable and you really have discomfort when you're doing it, don't do it. Take that week off. But when the catheter comes out, you must start doing it. You must start doing it if you're going to get control. At one time, when they were doing these surgeries and stuff, basically everybody was wet afterwards. Occasionally you run across somebody that's dry right from day one. And I hope you all are. I hope you're all dry from day one, don't have any problem. But it probably won't be the way it is. You're probably going to have some leakage problems. But they've gotten a lot better. There's a lot less leakage because of the different types, this robotic surgery. They've learned different techniques. They've gotten better at it. They're doing, getting better procedures so that keeps you dry. But again, you want to do those exercises, start them now. You want to continue doing them. You want to do them after you get your catheter out. You're going to be doing them 10 years from now. You have people call here, they get dry, say 3 months after their surgery, they're basically dry, I don't have any problem, but they start leaking. And when they call here, you said, are you doing your exercise? Well, no, I haven't done my exercise really in 6 months because I've been dry, I don't have any problem. Well, you have to continue. This is a lifetime commitment, man, and you're going to be doing your exercises. They don't take that long, and they don't know, you're watching TV, do a series of exercise. You're standing at the grocery store with a shopping cart, stand in line waiting to get checked out, do a series of exercises. Nobody knows what you're doing. You're standing there counting in your head, but you're doing those exercises to strengthen up that perineal muscle. The next page over here talks about the bladder control ladder. Gaining control of the urine is a very difficult time period. It can be very frustrating. It's very important to remember that gaining control takes time. It takes patience. It's also like climbing a ladder. There are several steps that you need to climb before you make it to the top, which is full control. Once you reach the top rung of the ladder, it doesn't mean you can stop doing your exercises. There will be times when you may have a leaking accident. So if you go down to the bottom of the page and you start up the ladder, the first thing you're going to feel is if you're having leakage, incontinence issues after the surgery, you're going to get the sensation returns that you have to urinate. When we're talking about the leakage here, it's not that all of a sudden you're walking along and you just get wet. What it is, it's a leaky spigot. You can't get the valve shut tight enough, and it's a drip. So as the urine is produced and then the bladder coming into the bladder and it's coming out, you're not able to get a capacity in there. It gets out the end, you're not tight enough, and it's a drip that comes out. So if you're getting an urge to urinate, that means you're getting the valve tighter, you're getting that drip stop, and your bladder's starting to fill up with urine. So it tells your brain, hey, I have to urinate. I have to go to the bathroom, go pee. So that's the first sensation you're going to get. You're going to get a volume back in your bladder. Next is when you're in bed at night and you wake up and say, I have to go to the bathroom. Let's go in and relieve myself. So you're able to get up out of bed. You're keeping yourself dry. Now you're laying down in bed. You're relaxed. It's less pressure. Your body's not pushing down on your bladder. and the gravity is not pulling, you're laying flat. But when you get up, you're able to keep yourself dry, get into your bathroom and relieve yourself. Next one is when you're sitting up in a chair. So you're sitting in a chair like we are here, or you're watching TV. There's more gravity, more your organs are pushing down on your bladder, but you're able to keep yourself dry and get into the bathroom to relieve yourself. Next, the last one is when you're up around all day long like you are now and you're staying dry. You may not ever get completely dry. Well, I'm saying you're going to be dry, but you may have leaking accidents. You may be dry all the time, but you're coming home, you're getting out of your car, you're opening your door, you're standing up, and you cough or you sneeze. The sneeze catches you off guard. And that's what we call a stress leakage. It's a quick hit, that quick pressure, and it catches you off guard. You might get a spurt of urine out because you don't have all the strength there to keep it back. You may never get rid of that. You may have a little bit of stress incontinence, but hopefully you get dry, more dry. There's different things you can get on your phone. Get in YouTube or look up Google, look up Kegel exercises, pelvic floor exercises. They have a whole bunch of exercise routines. It's like the old exercise videos of Jane Fonda back and stuff. They talk you through, they count for you, they do different things to help you improve, to get better. And if you're not getting better after a little while, call us. Talk to the doctor. Make an appointment, get in here. There are different medications to help. We have a nurse here that comes in on Mondays. She has a clinic she runs on Mondays just for that, for incontinence issues, that works with you about an hour or so, talking to you about doing different things and to get you back, to get your continence back. Women know more about this because of childbirth, because the anatomy is different. Women have a lot more incontinence issues, especially as they get older. Usually takes them about 8 years to call a doctor looking for help. Men, we're 24 hours. So we're not patient when it comes to when we get wet that time. We want something done now. We want it fixed now. But sometimes it takes a little time. So you just have to be patient, and you should see improvement. If you're not getting improvement, give us a call. The diapers, the incontinence pads and stuff. Same thing. Baby boomers, doing it again. They sell more incontinence supplies and pads to baby boomers now than what they do newborns and toddlers. So we're the big target group now. And you can tell, you go into the cheapest places to get them is like your Walmart, your Targets and stuff like that. And you go in there, there's a whole aisle. One side's men, one side's women. The whole aisle you got to pick from. But you want to get the pad that just fits in the front. That's what you want to get, because we want to get you dry. All right, next one here is frequently asked questions and the answers. There's bleeding in the catheter, around the catheter, at the end of the penis. Is this normal? It is normal. Urine may change colors as part of the healing process due to bladder spasms or bowel movements. May be totally clear. They may be pink or light red. This should clear up with rest and drinking plenty of fluids. The concern is if the urine gets like Hawaiian punch or ketchup, this could mean there's more bleeding inside, and you should be checked. And it's redder than Hawaiian punch. It can be the color Hawaiian punch. If you sit down and start pushing some fluids, and like I said, 15 minutes later it's clearing up, you're okay. If it gets that ketchup consistency and you're getting a lot of blood clots and that, then that's something. Something is bleeding there that we should take a look at. Is leaking around the catheter normal? It's due to bladder spasms, so you want to be using that ditropan, or the generic name is oxybutynin, that's ordered by the doctor. What should I put on my incision? Keep your incision open to the air. You can cover it with gauze bandage if your clothing bothers it, but be sure to keep it clean and dry. There's no need for any special soaps. Just clean it with soap and water. So when you're in the shower, just clean it with soap and water, dry it off. Nothing special. Can I take a laxative since I haven't moved my bowel since coming home from the hospital? You may use milk of mag or Ducalax tablets, but again, nothing into the rectal area. No enemas, no suppositories, nothing like that. And the constipation can be caused by the pain pills you're using, so it's important that you use the stool softener that they tell you to take when you go home. You're having loose bowel movements. Do you continue the stool softener? No, you don't. You can stop the stool softener if you're having diarrhea. You may take Lomotil or Imodium. And anything you normally use over the counter you can take. If it's not clearing up, give us a call. The doctor can prescribe you something. Do I have to get the pain pill prescription filled? No, not if you're not having much pain. If you think the Tylenol ES is enough. You don't have to get this filled, but you want to get at least a half prescription filled when you're getting it filled. When can I go back on my aspirin or any of the blood thinners? Don't start back on the aspirin until the doctor says it's okay. They're going to talk to you on your post-op visit about restarting those medications. How soon can I start doing my exercises? When the catheter is removed, you can start doing your exercises slowly. But you don't want to do anything strenuous until the doctor says it's okay. So usually after that first post-op visit, they'll tell you what you can start going back, getting back to your normal routine. But again, it's bicycle seats. You don't want to be sitting on any bicycle seats for a while. Why am I so tired? Why am I so weak? Your body has gone through a big operation. It takes 6 to 8 weeks to heal. Your stamina has to be built back up slowly by resuming your normal activities. When can you expect to have intercourse, or when can you expect to start getting erections? Usually after about 6 months of the general rule. If you had normal function before, it comes back sooner, so it'll come back. If you are having trouble, there's a lot of different stuff out there you can talk to a doctor about. You've got medications, you've got your Viagra, Cialis, Dendra. They have injections, they have vacuum pumps, they have all kinds of stuff there. So that's something you talk to the doctor about down the road. Is it normal to feel depressed? It's okay not to want to do anything for a short time after the surgery. But if it continues and you're really down in the dumps, you could be depressed. So you want to talk to somebody. Talk to a doctor here, talk to your family doctor. Everybody deals with this situation a different way. In the next couple pages, there's talks about that. This next page, this is different websites and stuff that are available for it's prostate cancer support groups and resources. You have the American Cancer Society, Men's Health Network, Prostate Cancer Foundation. These are all websites you can get on, look up things, and they give you information. Down at the bottom here, it's a Lancaster General Hospital Prostate Cancer Support Group. The next page over is about that. They have a cancer support group, prostate cancer support group, right here at the Amby Barshinger Cancer Institute. It's right down here around the corner. They have it from 6 to 7:30 on the second Tuesday of every month. Don't have it July, August, or December, so we don't have it here in December. Well, that's past anyways. There's a phone number down at the bottom of the page here you should call to register. I recommend you come to at least one of them. It's facilitated by Nurse Navigator Nicole Mills and then Chaplain Randy Keener. They have, there's a lot of topics. There's a lot of changes with treatments and stuff with prostate cancer, and there's a lot of things to it. There are a lot of men, they look forward to coming to these. They, meet that once a month, talk about new things that are out there. They have a lot of they could answer a lot of your questions that you have. They know where they get the best pads, what they thought the best pads were, where the best prices were. It's a good support group, and they know a lot of times about things that are coming out, things going on before we do, before I do, the doctors do. They know more about it than what the doctors do than what we do. Because they're involved. They've gone through this. They've been there. So I recommend go to one. Now they weren't having it during this pandemic. I talked to them probably about 4 months ago, and they're just starting up. They were just going to be starting up that next month. That was about 4 months ago. And as far as I know, they're running now. But with this uptick again now with the virus, they might shut down again. So you want to call that number and talk to them. They might cancel out for a while, not have these meetings for a while again. I know they restarted it, but again, with this starting now, everything's starting to change again. So, but I highly recommend at least go to one. Next couple pages here, we're talking about diet. We're talking about fibers, high fiber diet. They recommend fiber, getting more fiber. Down the bottom of the page, they just give you some sources of fiber. The stuff to the left are excellent. The further to the right you go, the less fiber there is available in the product. Next one's heart healthy diet recommendations. They talk about what fats to choose, fats to avoid, fats that are good, proteins that are good, proteins that you should avoid. It's just giving you a little help they're trying to on diet after the surgery. Then we come to a page here, vitamin D. It's up in the corner, says the female patient. And that used to be the case. Now it's vitamin D they're recommending basically for everybody. Vitamin D known as the sunshine vitamin. They've been recommending vitamin D, especially postmenopausal for the female patient because of weakness in the bones, bone fractures and that. You get your vitamin D down on here. It says food sources. It's hard to get. It's salmon, mackerel, tuna. Fortified foods is in margarine. They put it in milk. They put it on some breakfast cereal. But if you don't drink milk, and if you don't drink your milk off your breakfast cereal that has it on, you're not getting it because they spray it on the breakfast cereal. When you pour your milk on, it washes off in the milk. So if you don't drink your milk after you eat your breakfast cereal, you're not getting your vitamin D. So they recommend you take a supplement a day. Sunshine is where you get a lot of it, but this time of the year you can sit outside all day long with no clothes on. You're not going to get any vitamin D. The sun's too far away. And plus, when you are out, your skin's all covered. You've got coats, hats, and stuff on, so your skin's all covered. In the summer, a lot less people get because of the skin cancer awareness and stuff. If you're wearing sunscreen, you're not getting vitamin D because that blocks the absorption of vitamin D if you're wearing sunscreen. So they recommend vitamin D3, 1,000 to 2,000 units daily. They've gotten it more with men because they've gotten brittle bones with some of the stuff. Now you're having the surgery, but if you weren't having the surgery, one of our ways we treat prostate cancer is manipulation of the hormone. We try to manipulate the testosterone production. When we stop this testosterone production, we've weakened the bones. We found out, they start getting fractures. So we put everybody, we're doing that on vitamin D supplement, but they recommend that anybody gets on it because they've done a study, say elderly people are having trouble walking, they're using walkers, they're not having good balance, they put them on vitamin D supplements. 6 months later, they're not using their walker anymore, and they've got better balance, and they're walking along better. Things get stronger, the bones get stronger. So that's your decision. And that's what they're recommending now. Who knows, a couple months from now, they say it might be the worst thing you ever could do. Just like the aspirin thing here now. Now they say stop taking aspirin. Everybody's supposed to be taking aspirin. Now they say don't take the aspirin. Next page here is it's just cancer information, exercise, staying fit while you're being treated. Now we're coming to the last page here. This is about your catheter, your home care, taking care of your catheter while you're at home. This is the catheter. It's called a Foley catheter. It's named after Dr. Foley. He's the one that invented the way of, there's two ports here. There's one here at this end, where the urine comes out. Then he had another tube runs along. We put a syringe on this yellow part here, push sterile water in there. And on this end, there's a balloon that blows up, and that's what keeps it in the bladder so it doesn't fall out. At the top here are the openings where the urine comes through called eyes. They're on each side. Down below it there's a little ring, and that's where the balloon inflates and blows up. And the balloon's about the diameter of half a golf ball or so. That's what holds it in place. This is probably about the size of the catheter you come in. They're all that you're going to have in place. They're all the same length, but they are different diameters. This is what we call a 20 French. This is yellow. You may have one, it might be blue, it might be purple, something that goes on what the diameter of the catheter. But this is probably about the size you're going to have in. So this much of the catheter is usually in the bladder, come out the penis. This will be on the outside. So the urine is going to come out of here. So as urine is produced, comes in the bladder, it's just like a garden hose. It just hits the hose and it's going to drain out. So we need to collect it on the outside with something. So this is a leg bag. The Foley catheter, this is latex, it just pushes down over the top here. So as the urine comes out, it goes into this bag. Bottom of the bag, There's a valve. This is to empty it. This, you twist that. It doesn't come all the way off. You just twist it, not real hard, but to where it stops. So you have this lean over the toilet. You drain that out. You twist it shut. Just snug it. Don't twist it real hard because you can strip it. Just snug it down, then take a toilet tissue and dab off, dry off the end if there's a drop of urine on it. The leg bag has elastic straps. There's a button on each strap. So you want to put it on your leg. You put it on your upper thigh. Strap it around. And you make it snug, but don't make it real tight that you're cutting your circulation. Lower strap can be just above your knee or just below your knee, wherever you're comfortable. You want to keep the catheter bag, when it's on your leg, keep it up higher on your thigh. This catheter, where it comes out, you want this loose. You know, you want this slack in it, so it's not pulling on your bladder neck, or on the bladder. I've had people call, they're having pain, they come in, the bag's down around their ankle and the tube is stretched like that. You know, you don't know, you don't wear these, you don't know what, that's not good, that's uncomfortable. So you want to keep slacking that, you want to keep it up. When you take this off at night, this is the bedside bag. It holds a lot greater volume, it has a long tube. Take alcohol with a cotton ball, wipe off this end, pinch this catheter off, wiggle it off, transfer it over to this tubing here. This bag, take the straps out, open up the bottom, run some water, just tap water through it, rinse it out, let it hang in your shower or whatever, someplace in there, someplace where you can let it open, lay it in a hand towel, dry it off. So you can put this back on in the morning. This, like I said, it's a lot bigger. This bag here, this is where you empty it here, you slide that tube out. This has a slide valve on it. Slide it over, that opens it up, that shuts it. This bag usually always has this type of valve. The leg bag might have this type of valve. It might have a flapper valve, a little paddle that drops down. It's usually going to be this, or it's going to be this. Lately I've been seeing this valve on this bag, which I like better than this, but that's the one I've seen on the leg bag. So this is a lot bigger. This should hopefully get you through the night. Might not. You might, if you're drinking a lot of fluids, you might have to get up and empty it once a night. You don't want to let the leg bag get over about 3/4 full. When it gets close to 3/4, you want to go empty it, because that's putting a lot of tension on it. This has a hook on the back of the bag. Take the clothes hanger. Put the hanger between your mattress and box spring. Let the corner stick out, and then hook that over the side of your bed, whatever side you're laying on. So this is it's lower than what your pelvis is, than what your bladder is. They both have what we call an anti-reflux valve here, a little flapper that the urine shouldn't, once it's out, shouldn't go back in the bag or in the bladder, but they're not 100%. So you always want to keep it a little lower to keep the gravity flowing. You can wear this. This is the one I recommend you take a shower. It's all vinyl. Just let it lay on the shower floor. Dry it off with a towel when you get out. You can wear this around the house when you're doing things in the morning. You know, just if you're sitting watching TV, don't have it hanging off your lamp beside you. Have it on the floor. Let the gravity flow. Don't forget it. You know, you only forget it once or twice, because it'll remind you real quick as you're walking away. I'm laying back here, you gotta come back and take me with you. So you want to pick it up and just keep it a little lower than what you are. But the same thing then with this in the morning. You know, put your straps in, put this on your leg, take a cotton ball, a little alcohol, wipe off this end. You want to wiggle this back, keep it pinched off, transfer it over, push it down over your bag. This is the one you're going to be taking your walks with, going out shopping or doing anything like that. This is the one, you have it under your pants, nobody even knows you have it on. But you want to keep it up on your thigh, up above your knee, keep slack in it. It's not a lot of fun, you know, with the catheter and stuff, but you'll get more used to it in a day or so. And it sounds like a lifetime, but it is only a week. There's people that do wear these for a lifetime. They wear them. You get bagged, one bag of each. You shouldn't have any trouble. If you would have a problem with defective bag, or if it would leak or get split, we have them here. Just call the office and have somebody come over, and we'll give you a bag to replace the one you're having a problem with. If you want to take a look at them, you can take a look at them. Last page on here is just a questionnaire, and it's up to you if you want to fill it out when you're coming in for your appointment. Just ask questions. If there's things that you're upset about or things that you liked about things, things that were good, you can comment. That's up to you if you want to do that. Any questions? We got done early here today.
We got two.
Yes, sir.
So the first question is, right now, just under normal circumstances, I, go to the bathroom 3-4 times a night. I've accepted it. My question is, after this surgery, in 2 to 3 months, will that go away?
Probably yes.
Okay.
Probably it would go away. Most of the time it's because you're having what we call nocturia. The reason for getting up is also enlarged prostate and stuff. You're not probably emptying yourself out. You always have some laying in there in retention, and some of it could just be from irritation. Since your prostate will be gone, you will probably go back that you might not sleep all the way through the night, but hopefully it's going to go down maybe one time a night you have to get up.
Okay. Second one is just your opinion. I have a scuba diving vacation set up for 7 weeks after my surgery. I asked Dr. Versinko, he said, well, I'm not going to tell you you can't go, but he said it's going to depend on how things go.
Yeah, it should depend on how. You'd probably be okay. We're talking 7 weeks. They feel 6 weeks you're pretty well healed. Like if you were working and you wanted to go back to work, if you were working a desk job or something, usually 2 to 3 weeks they'll let you go back to work. If you're working construction or something like that, they say about 6 weeks. So they're letting you go back to that. So you'd probably be okay. You'd probably be okay, but that's up to you and Dr. Restickles. I know what he said. And he's pretty tough on things. He's a straight shooter. He'd tell you the way if he didn't want you doing it. Because that reflects on him also. If you start having a problem, then they'd say it's because the doctor's fault. So he wouldn't say, yeah, I wouldn't have a problem with him.
Okay, thank you.
Yep. Anything else? All right, well, I wish everybody well. I wish everybody has a great surgery. Everybody's dry right a day or two after your surgery. Or after the catheter's out. Not the surgery, but after the catheter's out. Have a Merry Christmas. Happy New Year.
Same here.
Thank you.
You're free to go. Anybody have appointments or anything today?
I got a call from the office here.
Yeah. Okay. That might be something.
So you're saying don't wear, I had on Amazon, I had ordered a pack of those, like adult, but it said when you wear them, nobody will be able to even tell you how.
Yeah, it depends. They say don't wear that stuff and that. If you want to wear that at night to make sure you're staying dry, especially depends on how much you're leaking and stuff.
Yeah.
There's no problem with that. You're not going to get depends, but when they're up and around, they want you to really work on your process of doing your exercises to get yourself dry. And like I said, it's a lot better than what it used to be because of what's going on. Yeah, you're free to go.
Okay.
You're welcome.
Thanks.
So but it's not. I wouldn't send them back or anything. You probably could use them. All right, good luck. You're welcome.
Well, at night.
Do we get it, Neil?
Wow.
Huh?
I don't know. We'll find out. It looks like it.
Okay.
Looks like
This is
it.
the third
Do it all over
time.
again?
The third try.